Hello everyone. Welcome to the Health Imperative for Safe and Resilient Communities featured event. Huge thanks to you all for coming. It is tremendous to have you here, so thank you so much for being here. My name is Virginia Murray. I'm the Head of Extreme Events and Health Protection for Public Health England, but I'm also a member of the thematic platform on emergency and disaster risk management for health. It's a huge privilege to be part of it. This platform, the thematic platform on emergency and disaster risk management for health, is there to advocate, share information and catalyse action on emergency and disaster risk management for health. It is also there to implement the Hyogo framework for action through health and other sectors. Some of you may have been here on Monday when Jonathan and Alistair Humphrey chaired a meeting of the thematic platform. That was attended by over 150 with 25 presentations reflecting the breadth of the health dimensions of the emergency risk management. And please note, it is the World Health Assembly this week, so I'm really grateful for all our health colleagues being here. The platform also coordinates input to the UNISDR system and provides a range of projects, publications and activities with the driver to share all in the interest of people's health. Many of you will have found many of these publications on the back tables. There are plenty of copies and we very much hope you'll take them away. For instance, there is a report available on the work of the thematic platform and indeed its draft plan of action. It's there, and we very much hope you'll take it and read it and use it, and possibly join us in some of this work. Now, to come to the business of the day, this session, we have 4 incredible speakers on the health imperative for safer and resilient communities. We have Mark Jacobs, who is there. Thank you, Mark. Louis Puente. Thank you so much, sir. Atif Sheikh and Valerie Scherer. And then we have not Bruce Aylward yet, but he may yet be coming. Otherwise, Rick will be involved. So if we could move to the first presentation, Mark. Mark is the Director of Public Health in the Ministry of Public Health in New Zealand. He's going to be talking about the integration of communicable disease and health into the All Hazards National Disaster Management. Mark, thank you.
Thanks, Virginia, and I guess it's, well, firstly, it's a pleasure to be here, but also slightly intimidating being in a room of people who are very much technical experts in disaster risk reduction and emergency management, whereas for me, I'm just more of a generalist public health physician and I do a bit of it. So I apologise in advance if I sound that I haven't been fully educated in all of the details of this. But anyway, so I've been, as Virginia mentioned, asked to talk about integration of communicable diseases into All Hazards National Disaster Management. Virginia also made a point of encouraging me to make sure I try to stay on time. So what my outline is, I'm going to very, very briefly mention some of the aspects of the broader approach to disaster management arrangements in New Zealand. Then make some brief comments about that system in operation in relation to pandemic preparedness, and then make some brief comments about some of the benefits as I saw them, both in terms of preparedness, but also in the pandemic response, but also in health making a contribution to other types of emergencies. So I won't talk about that. I mean, obviously all countries have got their challenges when it comes to emergency planning. New Zealand is not alone in that. In terms of our general approach to emergency preparedness and emergency management, certainly our approach right across government is one of all hazards, all risks, multi-agency, integration and community focused, and all of the legislation and the strategies and policies and so on are all consistent with that general approach. So we have a national piece of legislation, the Civil Defence and Emergency Management Act, that I don't need to go into the detail now, but that sets the legislative framework. We also have a number of other bits of legislation that relate more to individual sectors, but they've all been designed to be part of that broader framework. We also have a national civil defence and emergency management strategy. Again, it's followed by all of the agencies in New Zealand, and again, it has some 5 key principles that are consistent with what I mentioned on the first slide. In terms of the national leadership and coordination, like most countries, we certainly have a system for that. We have a cabinet committee chaired by our Prime Minister. Then under that we have a committee called ODESC, which is a committee of chief executives of the different government agencies. And then below that we have a National Crisis Management Centre, and then each individual agency has its own strategic structures. A key part of that process is that when there is an emergency that's developing or having to be responded to, the Cabinet Committee identifies the lead agency, and then all the other government agencies all report to that lead agency as part of the national response. And that system that I described is paralleled at the regional level as well. One of the other things that's very important in our system is that we think it's important for the different sectors to use the same language and the same sorts of systems. And so, in effect, we are all trained in the same sorts of designs of emergency responses. Many of the agencies, such as my own, uses a system called Coordinated Incident Management System, but it's basically just about making clear about how you structure an emergency response, so that people can move from one sector emergency to a different sector emergency, and they'll understand what their role is if they're told that they're going to be the manager of planning and intelligence or whatever the function is. It also means the different sectors can talk to each other during the heat of an emergency response. I'll skip past that one. Just some brief comments about the system in operation. So when we went into national preparedness for influenza pandemic quite a few years ago now, that Cabinet Committee identified the Ministry of Health as the lead agency across government. That then meant that we were responsible for coordinating the preparedness across government, but not doing all the work of that preparedness. So there were many different agencies that were given particular tasks to contribute to that preparedness. We could task them with doing it, and they would report to us, and then through us to government. And that worked across the health sector in terms of updated plans, for instance, but also across all of government, and we also led the exercising of the plans. You don't need to go into detail of this, but one of the things we did was establish a whole lot of different sectoral work groups under this national preparedness effort, and we tasked different agencies to be the lead for those different bits of the work. And so we could basically say, okay, we need all of the biosecurity issues to be considered, and you, Ministry of Agriculture and Forestry, you go away and do that, and you report back to us every couple of months, and then you need to have completed that in 6 months to a year or whatever the time frame was. In terms of some of the benefits, and this is obviously a very quick run through given the time, but some of the benefits that we saw from that preparedness process, it led to very active engagement of agencies right across government in the process. As I mentioned, it meant that all those agencies were accountable to the Ministry of Health, well, to government ultimately, but through the Ministry of Health. We were using a common language, so that was very efficient. It also made collaboration easier. We were able to draw on lots of knowledge right across government, because obviously sometimes we have to remind ourselves in health there is wisdom beyond the health sector, and this system allows us to draw on that. It also built quite a few alliances across government and also into the private sector, which proved to be very useful. So alliances with Treasury, for instance, or alliances with the transport sector, both the airline companies and the Ministry of Transport. Another example was alliances with the supermarket chains, for instance, where they basically worked out how to make sure that we didn't run out of essential supplies. Another example was all of our border agencies. We tasked them with thinking about actions at the border, and they found that process so useful that they kept it going after all the pandemic process finished. So those conversations continued to happen. And obviously, another benefit is that it shares the load. It means that it wasn't just the ministry doing all of this work, it was everybody doing this work. In terms of the response and some of the benefits that we saw when the pandemic actually happened, not surprisingly, the preparedness across all the sectors really made response across all the sectors much easier. It also meant that it was very easy from day one what the governance and coordination processes were. So the Ministry of Health was lead agency for the response. Everyone knew what that meant and how to make that work. Practically, we could also draw on, you wanted me to hurry up? We could draw on human resources from other agencies as well. And so, for instance, very early on, we burnt out, if you like, our epidemiologists in the Ministry of Health, and so we just said to the Ministry of Agriculture, we would like your veterinary epidemiologists now. So there's lots of those sort of practical benefits. Just very briefly on benefits in emergencies that aren't directly health emergencies. Because, I mean, at the end of the day, as we'd all know, many, many emergencies have a health component. In fact, I suspect most of them do at the end of the day. What we actually found was that having that more generic approach and using the same sort of systems across government and making sure that people in the health sector were trained in using those meant that actually when we had a different sort of emergency, like the Christchurch earthquake, it meant that we could immediately be part of that response. We had trained health people that could just look after the health aspects but also contribute to the broader aspects, and it just happened automatically and quickly. And even at the time, people were saying, well, this was very useful that we had all the pandemic preparedness and pandemic response because it's made this bit of the response much easier. Now, if I have I got time to do my conclusions or no? Okay, well, you can have a look at the conclusions later on. It looks like I've used up too much time, but anyway, thank you.
Mark, thank you very much. A fascinating talk. Congratulations on the most tremendous work that you did. And it's very clear how well your platform on disaster risk management and health seems to be working really well. I'd now like to take the privilege of introducing Louis-Philippe Puente, who will be speaking in Spanish. So for any of you who are not Spanish speakers, there are translation facilities. He is the National Civil Protection Coordinator of Mexico. So we're really lucky to have you here. Thank you so much. He's going to be talking about multi-sectoral action in emergency risk management for health with a view and a focus on safer hospitals. So can I ask you to start, please, Louis?
Muy buenas tardes.
Good afternoon to all of you. I'd like to thank you for the invitation to provide a report on the perspectives in Mexico with regards to the multi-sectoral approach. I'd like to give you some history. In 1996, the Pan American World Health Organization, WHO, also organized an international conference on mitigation with regards to disasters to the health infrastructure. And this was done also with the Health Secretariat to define mitigation, disaster reduction strategies with regards to the hospital infrastructure. In 1997, the Mexican Institute of Social Security signed a cooperation technical agreement with regards to hospitals in order to confront situations with regards to disaster management. There were several tools that were instruments that were drafted with regards to hospital in 2004. The Pan American Health Organization and WHO had a slogan and a national policy in order to reduce, in order for disaster reduction. Then there was a conference that was convened where an agreement was signed for the Hyogo Agreement. Then President Peñata, who worked on civil defense together with other leaders, and thanks to this work, there's been a safe hospital program that was put into place and is responsible to the governance organization with regards to civil defense. And we established the different policies with regards to health and involved the other institutions from the private and public sector in order to put in place the different objectives with regards to evaluation diagnostic of the hospitals in terms of security and safety. There are 19 institutions that are involved, and we've had interinstitutional and intersectoral and multidisciplinary approach that has given results. With regards to this report, it was important for us to have support at the highest level. the Mexican Constitution includes this notion of health, and that depends and that the president is responsible for directly for health policy. And there was reference made to the different areas of health with regards to safe hospitals. Civil defense has a requirement that hospitals need to include aspects to do with the Safe Hospital program. And in 2012, the civil defense law was signed that includes an integrated risk approach, and in different articles there is mentioned that civil defense needs to take into account the different guidelines that are part of Safe Hospital program. In January 2013, we published a new standard from the Health Secretariat that established the minimum requirements with regards to health infrastructure and the different clinics as well that need to take into account these guidelines. With regards to those that evaluate the program, we have a training, an ongoing training that is online, and in order to be an accredited evaluator, an auditor, you need to fulfill some multidisciplinary requirements of the program. You have to be you need to pass an online exam as well, and you need to carry out 2 hospital visits under the supervision of a senior auditor. We have we have different institutions that are accredited to carry out these evaluations and audits. And we also have a program with regards to disaster prevention that allows us to identify the different hazards and risks on a geographical basis and based on the location of the different hospitals. There is a communication strategy which enables us to respond in real time to different disasters. This tool helps us to simulate disaster situations, in particular with regards to earthquakes. With regards to the audits that take place on an interinstitutional basis, the Civil Defense Agency has an IT platform that is called Integrated Civil Defense System, and this platform has 82.7% of all the information that come from the audit system that the hospitals are included. And this is then placed in a database of that includes all the risks. There have been over 200 audits, and this has taken place in most of the states of the United States of Mexico with regards to the different private and public institutions, depending on the complexity of the hospital. I'd like to summarize different information with regards to investment that have taken place recently. Based on these guidelines of the Safe Hospital program, we have hospitals that are part of the federal government system, the state secretariat system, the Mexican Social Security, the Institute for Workers in the Government, and the Oil Company of Mexico. It's an investment of over $2.3 billion of investment. With regards to investment in rehabilitating and improving hospitals, of the 4 state institutions, we have 552 hospitals or clinics with an investment of over $770 million. Now we're going to consider the government perspective over the 7 years of implementation of this program. It is clear to us that this can also be used in other sectors of the world. We're going to promote a Safe Mexico program that is relevant for different sectors, where we're going to integrate risk management in other areas in order to prevent and reduce the effects of disasters. For this reason, the President and the Secretary General of the government have put into place a Safe Mexico program that's been put in place. Thanks to this program, we're considering the tourist infrastructure as well, and on a functional and safety, health and safety basis. As you know, in Mexico, we have a disaster management fund, which is called FOPREDEN, and this fund provides financing for prevention of disasters through an analysis of the different hospital system data that is provided. We can manage the funds in such a way to also include the different hospitals so that we can strengthen the hospital infrastructure. These hospitals were chosen because they were located in vulnerable areas of Mexico on the coast and areas vulnerable to earthquakes. The President of Mexico has an objective that in 2015, 100% the greater and more complex hospitals should be audited and strengthened. Thank you.
What a tremendous achievement you're planning for Mexico. How exciting. So thank you so much. I now want to turn to our next speakers, who are two. And I wonder if we can have our signer come to the front. We are very fortunate to have a signer. So allow me to introduce Atif Sheikh, who is the Special Talent Exchange from the Special Talent Exchange Program in Pakistan, and Valerie Scherer from CBM, who are going to talk about the needs of people with disabilities in disaster risk management, and will provide an early release of a guidance note on disabilities and emergency risk management for health, which is really important because it will be formally launched on the 13th of October, which is the International Day for Disaster Reduction, which will be dedicated to disability. So really important. Can I ask you to start? It's you.
Thank you very much. Actually, it takes a lot of time to discuss how disabled people are, or persons with disabilities are neglected in the health, in the situation of disaster from the perspective of health. But very shortly, I would like to give you an overview through the help of some slides. Can you go to the, yeah, can you come to the next slide? Okay. Can you? If you can, yeah, previous one. If you can have a look on the slide, a girl sitting on the bed. She was left behind in her house after the flood in 2010 in one of the villages in Pakistan, because they were not prepared to take her with them. She has a muscular dystrophy, a disability because of which she can't move the limbs at all. And that's why she was left behind. And it's common that in most of the disasters, people with disabilities are uncounted even before the disaster, during the disaster, and they remain uncounted citizens after the disaster. The major reason why, because the humanitarian organization and staff, they don't know exactly how to deal with disabilities, how to prepare for people with disabilities to evacuate or to rescue them. And they are the last to rescue. Actually, people with disabilities are always counted as most vulnerable people in the disasters. They can be potentially advised on different issues. They can be potentially consulted. If they are consulted in policy making, in planning, then situation can be much better. And for that policy making and including persons with disabilities in disaster preparedness, we need a comprehensive guideline or documentation. I would now hand it over to my colleague Valerie to explain about that guideline.
Okay, so, well, as you heard from Virginia, we are going to release a guidance note on disability and emergency risk management for the health sector. It is very important because keep in mind that 15% of the population is disabled worldwide, which makes it a significant population. The guideline is looking at several principles and is getting all these principles all across the different sections. And it's looking at equality and non-discrimination, accessibility of infrastructure, of health services, of humanitarian worker, and so on. At participation and dignity of persons with disability, that's often sometimes we notice in emergencies, how do we respect the dignity of persons with disability who are affected by disaster, but also looking at how resourceful they are and how they can bring an added value to the health sector in emergency risk management. The guideline has 3 sections, and the 3 sections look at first the impact of emergency on persons with disability, but it also defines practical action related to emergency, and it recognizes that disability is a multi-sectoral approach. It's not a health issue, it's not a shelter issue, but it's going across the different sectors. The second section basically outlines the action that needs to be taken by all the sector, all the cluster in relation to health, and how the health practitioner can contribute to this action. And then the last section focus on disability and on specific action that should be taken to ensure that persons with disability can access and are part of the humanitarian response. Well, I done something wrong, sorry. Back? Well, anyway, that does not matter. I just wanted to show you one element of the guideline, which basically was about nutrition and food security and the kind of practical action that it is mentioning. And for example, it's looking at adapting the food ration to the need of a person with disability. This is a more specific action, but there are people who are not able to swallow properly or who need specific diet because of their disability, and that's important to look at those aspects and to prepare in advance, so when there is a disaster or an emergency, we can basically respond to those needs. And I'm basically on with the presentation of the guideline.
Thank you, Valerie. This guideline is really important. Thank you so much, Atif. Your presentation points to how valuable this guideline will be. The guideline is available at the back if you'd like to see it. There is much in there, and I know that it's of real value when we implement it. I'd now like to move on, and unfortunately our next speaker is distracted by the World Health Assembly, and I suspect he's involved there. So we're incredibly lucky to have Rick Brennan, who's the Director of Emergency Risk Management and Humanitarian Response at the World Health Organization. And he is going to tell us about the health imperative, developing a framework on emergency risk management for health from WHO's perspective. Thank you so much, Rick.
Thanks very much, Virginia. And I bring you greetings from Bruce, Dr. Bruce Elwood, our Assistant Director General. He is in a session at the World Health Assembly right now where they're considering a resolution and hopes to join us before the end of the session. Margareta Wallström often reminds us that, that the health sector is not, from her perspective, adequately engaged in some of the dialogues and initiatives related to disaster risk reduction, but I have to say, after hearing the earlier presentations, it's clear that in many respects, the health sector is actually a leader in this regard. So, I mean, very, very impressive to hear what's being achieved, and both in New Zealand and Mexico, and of course, this initiative with disabilities as well. Virginia mentioned, as you all know, this is the week of the World Health Assembly. It marks the second anniversary of the passage of a very important resolution for us, Resolution 6410 within the World Health Organization, strengthening national health emergency and disaster risk management capacities and resilience of health systems. And the government of Chile was an important sponsor of that resolution, and the ambassador of Chile, Ambassador Ayache, is here, and I'd like to acknowledge the ambassador and again thank him for his support and the support of his government and the legacy that they have left with that important initiative. So I'm going to walk you through a very important initiative that WHO is leading around an emergency risk management for health framework, the development of a framework which will really codify what we believe member states have to have in place in order to more effectively manage the public health risks of emergencies. And I think we all agree that the health imperative for disaster risk reduction and emergency risk management is very, very clear. Based on Red Cross data, over the last decade, on average, over 110,000 people died worldwide as a result of both natural and technological disasters. More than 240 million people were affected per year over the same time period. And this data does not include the impact of conflict, the health impact of conflict, or of complex humanitarian emergencies. For example, places such as Eastern Congo, Central African Republic. And by some estimates, the deaths and the health impacts of those types of emergencies dwarf the kind of data that we're presenting here. There are other clear public health consequences of disasters, mental health issues, disability, and then of course damage to health facilities and disruption of health services and systems, limiting people's access to much needed health care when they most seriously need it. And of course, the adverse health impacts of disasters can have run-on effects to other aspects of people's lives, including their education, livelihoods, and indeed development in general. But I think we are making good progress. I think we're developing momentum around the issue of emergency risk management for health. And just to share with you some of the recent progress that's been made in the area of disaster risk reduction generally and with respect to health specifically. As of last year, 130 WHO member states were documented to have had a national emergency preparedness plan. Very, very good progress and a great foundation to strengthen national capacities. Safer hospital programs, we've heard of the excellent experience with Mexico. More than 50 member states of WHO currently have an active safer hospital program. And through those various programs, more than 1,800 hospitals have been assessed up until 2013. And those assessments don't only include structural assessments, but they look at the way that hospitals operate and can potentially operate even after a disaster. And together with those assessments, there is planning and the development of measures for improved hospital preparedness and response when disasters do occur. Very importantly, one step forward that WHO in particular is proud about is the development of the international health regulations, which was undertaken in 2005 in partnership with our member states. The international health regulations lay out what capacities member states should have in place to manage, to prepare for and respond to public health events with public health consequences and international potential, such as epidemics, chemical spills, radionuclear events, and so on. To date, 40 countries have established the necessary core capacities as per the international health regulations. And I might say this is a legally binding instrument, an international treaty, and a wonderful step forward with respect to emergency risk management for health. So we want, I think that one of the concerns is that various disciplines within health and various initiatives related to emergency risk management for health have not been brought together under a holistic whole. Some of those initiatives have been somewhat fragmented. And what we are proposing and what we have started working on, again, with many of our partners, is what we are calling a framework for emergency risk management for health. We have a draft of that document and in fact conducted a consultation in November last year which was attended by 88 experts and senior partners, many of whom are here today. And essentially what we are planning to achieve, or trying to achieve with that document, is to outline the measures that member states should have in place to manage more effectively the public health risks of emergencies. Very importantly, we're trying to position health more centrally within the emergency risk management dialogue within member states. And we've heard from Mark today how effectively the Ministry of Health within New Zealand has positioned itself in some of the national emergency risk management initiatives. Moreover, this framework will clarify exactly what WHO will do to support member states, and it will also provide a framework for monitoring progress in the development of those capacities, and also in monitoring WHO's contributions. The framework itself is based on principles drawn from disciplines of disaster risk management, health systems, and the international health regulations themselves. So I think that we're all familiar with the way that we're starting to reevaluate the way that we approach emergencies. I think historically, the push towards more of a risk management approach has come from the fact that we've been in the past too reactive, responding to events rather than responding to risks and identifying hazards and vulnerabilities effectively. So to give you a sense of the shift in our thinking and the shift, I think, across the whole emergency risk management community, if you like, we're moving from an event-based approach to a risk-based approach, from being reactive to proactive. Instead of considering single hazards and preparing for single hazards, we're adopting all hazard approaches. We are adopting multi-sectoral, whole of society approaches, and instead of doing things for communities, we're working and planning with communities. The prepared community, of course, being one of the basic principles of effective emergency risk management. Some of the other important guiding principles that influence the framework are the comprehensive emergency risk management approach, embracing prevention, preparedness, response, and recovery. Multidisciplinary within various sectors, so engaging within the health sector, public health, as well as clinical disciplines, focusing on seeing that the contribution that effective emergency risk management for health can make to sustainable development more broadly. And of course, the big emphasis on community resilience, and there is a clear articulation of some of the relevant ethical considerations as well. I'm going to quickly whip through this slide. On the left, we actually have laid out the 7 different areas of which we believe member states need to build capacities, and these are clearly articulated in the draft framework. Policies, legislation, and strategies, and again, we've heard from New Zealand and Mexico today how important their own policy frameworks have been. Resource management, planning and coordination, and again, from the earlier presentations, we hear how important this is. Information, knowledge, and management, health infrastructure, logistics, and so on. And again, these various areas are drawn from the disciplines that I spoke to, that I mentioned before. I've contrasted that there on that slide with some of the core capacities within the international health regulations. I won't go through those in details. I think it's worth pointing out that the international health regulations are an important core foundation for our framework, but they are primarily event-focused, not so much an emphasis on managing risks at the front end. So we're in full swing in developing this framework with our partners. I think I hope I've been able to give you an overview of its core objectives and main elements. But that's not the only thing that we're doing within WHO over the coming 2 years with our partners. Not only are we going to finalise the framework at next year's World Health Assembly, we also hope to present a high-level policy document related to emergency risk management for health. We are going to continue our technical support to regional officers and member states. We are going to be reinforcing the Safer Hospitals Initiative, and again, you've heard how important that is through the Mexico presentation. We're going to be playing our role in the implementation of the UN Plan of Action for Disaster Risk Reduction for Resilience, and there was an important session on that earlier this morning. And we're going to more actively engage health within broader disaster risk reduction fora, including in the post-2015 consultations. And as you've heard from Virginia, there's a strong determination to strengthen the thematic platform on emergency risk management for health. So that's our plan for the next 12 months. I might just acknowledge Dr. Bruce Alwood, who's just walked in the room, on whose behalf I've just presented this short discussion. I might invite Bruce up to the platform so we can be ready for the discussion. Thank you.
Rick, you did really well, thank you. And welcome, Bruce, you made it. Don't go, Rick, please stay. So it'd be really important to have both of you. Just trying to encourage, that was all. But it was a fantastic presentation, thank you so much. That was really good of you. If we could go back to my slides, please, I'd be very grateful. I think we've had 4 amazing presentations, as I think you'll agree. Really key, these presentations. They pointed very much to the fact that health and the post-2015 framework for disaster risk reduction are key issues. Health is, in our view, should be a top priority for communities for disaster risk reduction. We think it's really important. And yet we're really quite worried that insufficient attention to people's needs and health outcomes and sectoral actions have been undertaken. So health and health outcomes are a measure of impacts of disasters and effectiveness of actions. They are a bridge for effective disaster risk reduction. They are core for social justice and a prerequisite for disaster risk reduction towards sustainable development, which Rick has just been talking about. What I hope to bring up next as a slide is really to take you through the 10 key messages for the future post-2015 framework on disaster risk reduction, to make sure that you see them and see if you agree or understand them or feel comfortable with them. The first is to agree on the principles and scope of the post-2015 framework, much of which Rick has summarized. To remind you that health is not just saving lives, but should be an explicit outcome. That we need to focus on community priorities, linking right to the front line, as has been really clearly summarized. That sectoral action should be emphasized, and health should be part of that sectoral action. I think Mark has summarized that really well with how you worked and got other groups to help you when you were doing your pandemic preparedness. And I think with the help of Atif and with Valerie, give attention to emerging and neglected issues, things that are so important that we don't reflect on often enough. But we also think risk management in health may be preferable to just straightforward risk reduction. We know that risk management is about the local events, and there are many of those, and the emergencies that relate to it, as well as the large-scale disasters. And I think the process that has been pushed forward by WHO is really key. And health, I think, really needs, and Jonathan, I know you've been very encouraging on this, the all hazards approach. We need to be able to respond to everything. And to do this, we need to promote science and technology, and to use this for research, and to get the research out of it that will help to influence our futures. And then finally, there's this call to strengthen the action and resilience of health systems, including safer hospitals. So important. So I just want to open the floor to the discussion. So I'm just going to give you a few thoughts about what this discussion should be about. First of all, do you think these are the key messages we need to focus on to achieve better outcomes? And are these the messages we need to take from this group to the post-2015 dialogue? Most importantly, will they provide the how to improve the health outcomes for people at risk of disasters? Because we now know that people are at risk of these disasters, but do we know how to improve it? And finally, for this discussion session, are these the priorities we need for the next 2 years? Is there anything that's missed? And is there anything that we should be asking our panelists for to help us guide us better? So let's open the floor to discussion. I see one there, and one there. Let's take 3 questions together. Could we have the microphones, please? If we could take 3 questions and then we'll just share them. We'd like questions, not ready statements, if possible. So really good questions, please. Be really kind of you. If you could give your name and where you're from, it would be lovely.
Yes. Very good. My name's Arno Rosmarin. I'm from Stockholm Environment Institute in Sweden. And I would just like to comment that I would have liked to hear the word water and the other word sanitation. I believe this is a neglected sector. It's the maybe last chapter in human development. And I don't challenge you as individuals here, I challenge your institutions that you're representing. In one of the handouts here on chapter 5, it says something about 115 kills per hour. So it is, if you like, a very, very serious and sensitive component in a disaster risk reduction scenario. So I emphasize that, and I encourage you to include that in your priorities.
Thank you very much. That's very helpful. I would like to point you to one of the fact sheets we have, if I could just take you through to them. At the back, you'll see a list of emergency risk management for health fact sheets. And I think you'll be very pleased to see that number 17, just because of its alphabetical nature, is water, sanitation, and hygiene. It is included. So that's great news. Thank you very much. Next question, please. There's one here at the front. If I could have you to the front. Here. There's a lady at the front, please.
Hello, I'm Marcy Roth, and I'm the Director of the Office of Disability Integration and Coordination at the Federal Emergency Management Agency in the United States. And I have a question for Atif and for Valerie. And I wanted to find out if, in those very important key messages, if attention to emerging and neglected issues gets at what you all were talking about, or if we are looking for something perhaps stronger or clearer in those key messages.
Actually, first of all, like I got a little time to explain that person with disabilities in the health perspective, they are treated as patients all the time. They have, like, health professionals try to fix them or focus on the rehabilitation only. So we need to look disability from social and development perspective as well. We need to find out how we can enable the environment where people with disabilities can survive or they can have a better life there.
Thank you, Atif.
Well, I think in the context of the health sector, there are many other neglected topics than disability. And I think, well, it would be, of course, great for us if it goes further than that. But I think it's already good because then you include many other issues like elderly, other groups who also have very high health needs and needs to be covered.
Thank you very much. We've got several questions at the back. Could we possibly take 3 questions at the back, please? It'd be really kind of you. Sorry, there just seems to be one microphone running around at great speed. If you could just give us your names and help the travel of the microphone. It seems quite exciting. Thank you.
Yeah, thank you. My name is Kalambai Kalula. I'm the Regional Advisor for Disaster Preparedness and Response in the African region, WHO. An issue which was not on the key issues, it's what are the innovative measures to mobilize resources to make this happen? It's not there.
Thank you. I might ask Bruce to answer that, just so you know, Bruce. Okay, could I have the next question, please? The white shirt, I can't quite see you, I'm so sorry. Just by you. Sorry.
Hi, I'm Saab Johal. I work in disaster mental health in New Zealand. It was really pleasing for me to see mental health mentioned there as a possible consequence and health imperative for DRR. And I see that in the 10 points that are focused on community resilience is certainly there, which is a related issue. But I think the mental health and mental well-being of individuals, families and communities are interrelated. And I was wondering, Rick and Bruce, whether you think that there might be an opportunity to perhaps clarify that, particularly in the emerging and under-focused section.
Thank you very much. If we could have one, can you just pass the microphone to the next person just next door to you? That would be really kind. Thank you, Saab.
Thank you very much, ladies and gentlemen. I want to focus especially on the use of technology in supplying for emergency health service, like a drone, for example. I think drone is very useful, not only for fighting, but for humanitarian action as well. Second thing, if you could put forward water, move it from the 17th position to number 1, because water is the rule of thumb in survival. And most of the time, people have everything except water. And also, last, appropriate technologies, like a bicycle, because sometimes you have no access with airlift or with boats or cars. Just a bicycle can help to carry. Thank you.
Lovely comment. Thank you very much indeed. Bruce and Rick, if you could start with the first two, please.
Thank you, Virginia. And good afternoon, everyone. Apologies for being late, but I think as you heard, there's a little meeting related to health going on up the street called the World Health Assembly, and I happen to have a big role in that, so I'm afraid I was stuck with that. Apologies. I want to start actually with a comment, Jeannie, to what you started with, saying that about health being a top priority, and I don't think it's a top priority in the post-2015 agenda. I'll disagree with you on that, because I think what we need to make the post-2015 agenda about health and health outcomes, quite frankly. And the case for this is so compelling, and I think as we look at going forward, part of it is our ability to communicate and make that case. And today's session obviously was very much focused on community resilience, on safer communities, etc. And as we talk about disaster risk reduction being people-centered, we come back again and again to this issue. It's got to focus on what's important to communities, obviously, if that's going to work. And poll after poll after poll, when you ask them what they're worried about, they worry about their health and the ability to protect their health. And I think a lot of it is our ability to communicate that more compellingly. And, one of the very first things we're going to have to do is demedicalize the word health. Everybody thinks health is something that doctors do, and health is something that happens in hospitals. And I think, the comments made about water, first and foremost, if you look at the work we're doing on the health emergency risk management work, water's right at the center of it. And clearly people working on water are dealing with health. People working on food or nutrition are dealing with health outcomes. And I think a big part of our challenge is really making that case. And I think we got off to a good start, actually, this morning. When I say start, my morning started at about 7 o'clock across the street. We had a meeting with the Deputy Secretary General and with Margareta discussing the UN Plan of Action for Disaster Risk Reduction. And the very first commitment is to our work to improve health. So it's captured right in the very first commitment. So I think that case is starting to be made, because that is a document that speaks to the entire UN system's commitment. So I think that we're started, and I think your list of priorities our list of priorities is going to be a good place to start. But a big part of it is going to be communicating, and a little bit our ability to what's the word, medicalize, I keep saying, or demystify the word health and change that. So on water and sanitation, yes, it's definitely right at the center of the agenda. And obviously we're going to have to reorder the alphabet, and we'll do that later today to make sure that it's at the beginning. There are important questions about how we resource this, and of course, when you talk to a bunch of resident coordinators in the UN system with the Deputy Secretary General in the room, and you talk about DRR, the only common theme is money and who's going to pay for it and how. And the DSG, Jan Eliasson, he was really straightforward. A lot of this is going to have to come from within programs already working and rethinking how they prioritize their work, because we're in an extremely tight economic environment, quite frankly, and we're going to have to be really, really smart about how we do things. In a tight environment, however, it's when people will prioritize those things that are going to be your high impact and best buys, and that's again where the case for disaster risk reduction for health outcomes, I think, is so strong. There's not going to be a lot of new money in the system for the next few years, and if we wait for that, the agenda is going to stop. And our agenda is influencing the post-2015 yoga framework. We need to be working, I think, for the moment with resources we have. Now, that said, this obviously is a rising issue on the development agenda as well as the humanitarian agenda, so I think there will be additional resources, but we certainly aren't planning to wait for it, as you heard from Rick. That's our agenda, and we have to do it with what we have at hand right now. Question raised about mental health. I've rambled on for a while. Rick, I don't know, do you want to take that? Or? I'm happy to take that and take the rest of the questions, but let's share a little bit.
Well, I think that I think there's a wide recognition that mental health is one of the more important health issues to be addressed in humanitarian action and disaster management generally. And I like to think that we've made a lot of progress in recent years. In fact, of all the technical units that our department works with at headquarters, we get more support and more engagement and more productivity with our mental health team than any other. And I think we've been very, very...
Scan the audience to make sure none of the other ones are here.
Yeah, I did. We're safe. No, and when I think of some of the advances that have been made, the mental health and psychosocial guidance, the inclusion of a specific standard on mental health in the SPHERE standards, a lot of the improved research that's being done showing that there are some actual interventions in mental health that can have impact following emergencies and so on. So, and of course, I think that there's a broader recognition that good mental health is absolutely critical for resilient communities. And everything we do around resilience, I think, is very important for psychological well-being as well. So, couldn't agree with you more. Mental health is an incredibly important issue. It's something that we measure from time to time. In refugee and disaster-affected populations, but we've got to, I think, come up with more effective interventions as well that we can demonstrate to be effective.
Thank you, Rick. That was very helpful. Thank you, Bruce. Luis Philippe, could I possibly ask you to address the last question about technology, appropriate technology, water and nutrition, all these things that were addressed earlier by our colleague over there?
Thank you. Yes, when I was hearing the question, there were two areas that I was thinking about. In a country such as Mexico, where we suffer from drought, for instance, this year, the dams are less than 25% of their level. If we're not careful about water, it's going to become an increasingly severe problem for us. The national water system is concerned in terms of access to water. Hunger and drought are two combined areas with regards to rural communities. And this with regards to the efforts that Mexico is making with regards to technology, if you consider, for instance, a bicycle, those rural communities very often, we don't have, with regards to the evaluation of cost, cost of living costs. We haven't considered all the aspects because we haven't been able to reach those communities, and they've been very much affected because we haven't spent enough time in terms of quantifying the different aspects. We have to consider communication with the cheapest system so that small rural communities that are far away from urban centers, we need to understand better their needs because those communities are often greatly impacted by disasters. With regards to drought, the country is working very much with regards to the water distribution system and irrigation, so that the poorest communities that are the furthest away can also have communication means in addition to water.
Thank you very much, Louis-Philippe. Could I have the next 3 questions, please? Let's have a quick row here. If we could just go to these 3, if we could go there, and then I know there are many more. So can you ask very short questions, and let's ask the panellists to be quite short in their answers, if possible, please.
This is a very quick question. My name is Alistair Humphrey. I'm a public health physician in New Zealand, and I was very closely involved with the earthquake there. Quick question really to the people from WHO, possibly to Mark too, because Margarita Wallström, Margaret Chan have both talked about the importance of the international health regulations as we move forward into the post-2015 framework. It's also been pointed out that the IHR does deal with events at the moment, infectious disease predominantly, rather than the risk management approach that's being advocated. How, in your view, Bruce and Rick, and possibly Mark as well, how are the international health regulations going to be manipulated? How are they? What is it you are going to do to get them to kind of fit in with the post-2015 framework?
Thank you, Alistair. Could you just move the microphone to the left?
Thank you. I am Rehana from Bangladesh. My question to World Health Organization. Your presentation is very nice and your action plan is very nice. And my question is, have you any plan your disability-friendly hospital and disability specialist doctor in any country and any hospital? Thank you.
Thank you very much for that question about having disability planning and disaster risk reduction inside hospitals. I think I reflect. Louis-Philippe, can you answer that one later?
Good day, I'm Mel Reedy from South Africa. Just a concern with regards to the FHA2 and the key objectives that you identified or highlighted. I'd like to see issues around quality, because when one looks at having to provide impetus to health, or within having to say it needs to be incorporated within HFA. At the same time, the issues around quality, perhaps uniformity in terms of standards, with very clear goals and very clear indicators in terms of having to assess the extent to which health and the issues around that would be addressed. Thank you.
Thank you very much. If I could possibly ask Mark to start responding to the question from Alistair about the international health regulations. Maybe Rick could pick it up. The question about Bangladesh and disasters and disability, if I could ask Louis-Philippe to do that. And then the quality, I wonder whether you pick that up, Bruce.
Yeah, thank you. In terms of the IHR question, and thank you for the interesting question, Alistair. I was assuming you were going to ask something that was interesting. I guess I'll give you a view wearing one of my other hats, which is the IHR national focal point in New Zealand. So each country has a national focal point that's responsible for implementing the IHRs in that country. So again, that's one of my hats. I think from a country perspective, the main way of trying to maximise the value of the IHRs for broader disaster risk reduction is by trying to make sure that the capacities that are being built in the country aren't just being built to be able to respond to potential public health events of international concern. They should be about building broader capacities to have really good surveillance of developing threats in the country, good communication systems, good response systems, good systems so that the sensor is linked well to the regions and to the districts in terms of both surveillance and they were saying sort of response. And I think the countries are up for that. Certainly the countries in our region. I mean, I spend a lot of time working with Pacific Island countries where obviously resources are extremely limited. They don't want specialist things. They want things that are useful for lots of different purposes. And I think that's the trick with getting the maximum value out of the IHRs.
Rick, can I ask you just to do a more international comment?
Yeah, we decided he heard the quality question and I heard the IHR one, so I'll comment on that one. And actually, I'm going to reinforce exactly what Mark said. But first, we need to be clear. There's many, many things you can do with the IHR, the International Health Regulations. One thing you can't do is manipulate them. I think, as you know, every word of that damn thing was hours and hours of negotiation. So we're pretty locked into the language. But the language is fantastic, in fact, and most people don't recognize that. And I don't know how many countries have suffered a natural disaster and said to us afterward, you know, it was the pandemic preparedness stuff, or it was the IHR work that we done on core capacities that really let us respond so much more effectively. So what we're really looking at, I'm talking facetiously, of course we're going to manipulate them. No, what we're going to do is actually build on the IHR. And when we look at the emergency risk management for health framework that we have, if you envisage it, you know, we've got the hazards across the top and we've got the you know, disaster cycle down the side. Basically, IHR fits sort of, it covers a domain in the middle of it, really. And what we're looking at is how do we extend it further up toward the risk management, identification, and management side of things rather than just the events. And then how do we extend it this way into some of the natural hazards that we're trying to address and even conflict situations. But it's pretty robust framework, a lot of it. With a little bit of imagination rather than manipulation, you can go, I think, a long way, as Marcus said. And that also speaks to two other issues. The first is the one of efficiencies. Within our organization, you know, there's no way that particular Margaret is going to agree to us to have an IHR program of work here and a preparedness program of work here. It's got to come together, coming back to the question Columbi asked about resourcing. So this is one piece of it. And the other thing is right at the heart of it, if you've actually read the IHR, the term community resilience is in there and stressed as a key goal of it. So it gives us so much to build on because it's a legal framework which is signed on. Kathy, help me, how many countries? 194 countries have signed on to this legal framework. We don't have anything so powerful in the DRR world as something like that on which to build things. Unfortunately, it has health as the biggest word on the front of it, and everyone looks at it and goes, that's for the doctors, and you use that in the hospital. And that's, I think, a big part of what we have to address going forward.
Thank you, Bruce. Can we now talk about the question that related to preparedness in hospitals for managing disabilities? I'd very much like you to talk, Louis-Philippe, but I'd also like Atif to comment too, if I may.
Well, I'd like to, first of all, be very concrete with regards to Mexico specifically, because we have two exercises that we're carrying out with our brothers that have disabilities. There are two areas. First of all, there's the government action with regards to all the health systems, so that we have a very clear database of where our brother disabled are, so that this national database enables us to have information about their location in case of disaster. And the second effort is the private sector that have brought forward an effort so that all those that are disabled without any cost will be in a database, and in this latest government, the president has requested us that the organizations that work with disabled should identify what are the strategies we need to carry out so that we are more resilient and reduction of risk for this area.
Thank you very much. A very exciting response. You've got these exercises happening and all the other work. Really great work. Can I just ask Atif to make a short comment?
Yeah. Actually, physical infrastructure environment is to some extent accessible in all hospitals of the world, even in the developing countries. But including disability, as one of the participants asked from Bangladesh, that addressing disability in health sector is beyond rails and ramps. It also includes understanding of medical staff for sign language. There's no accessibility for the hearing impaired people in the hospitals. And secondly, there's a need of orientation of the medical staff on the inclusion side of disability, so that whenever there are information disseminated or health services are provided, people with hearing impairedness or visual impairment, they remain out of the mainstream. So we need to make these things.
Thank you. I love that comment. You're quite right. We must mainstream them. I think it's really important. Just before we start moving on to the quality issue, Rick, I just want to remind people that we are here to look at the 10 key messages. You should all have them. Just make sure you've got them, because this is the area that will get the next opportunity to do the questions. Just in front of me, on my right. So wait a second. So could we please go to the quality question now and get that answered, Rick?
Thank you. Yeah, I mean, I think it's an important question and an important issue. And anything we want to do in public health, of course, we want to do, or disaster risk reduction or an emergency risk management, we want to do with good quality. I think we have to define what quality is. If we're going to say, well, our DRR or our ERM for health projects are of good quality, we have to define what that quality is. And to that end, we have to develop standards, benchmarks, or whatever. I think we've got a good experience with that in our Southeast Asian regional office, where we have actually developed benchmarks for emergency risk management, and we are in the process with member states of measuring performance against those benchmarks. Within the emergency risk management for health framework, we talk about the development of standards and monitoring performance against those standards. So that's certainly going to be part of the body of work. We're not there yet, but there's certainly an intention to do exactly that.
Thank you, Rick. That was very helpful. We have three people who want to present here. Just a statement or a question.
Muchas gracias. Mi nombre es Jorge Díaz.
My name is Jorge Diaz. I'm the Vice Minister of Health in Chile. We are very interested to underline the need to have that the population be in a good state of health before a disaster. We think that the developing of policy that improves the health state of the population before a disaster in a country where we often have disasters. We just recently had an earthquake in the north of our country. We want the population to be psychologically and physically prepared to confront disasters. Then we had the Atacama mining accident, where there were problems, particularly because of the state of health before the accident actually happened, because there were mental health issues before the accident. Thank you.
A very useful statement. Thank you. Very important. Just back there, please. Thank you.
Muchas gracias.
Thank you very much. I'm from PAHO. The health services are very important for the men and women 24 hours a day and 7 days a week. Not only in emergency situations, but in situations and regular day-to-day situations. Because what's also important is prevention with regards to health. And with regards to this, the health services save lives and reduce disability. But they also contribute to reducing the risk of disease. The health services also need to achieve the MDGs, in particular with regards to infant and maternal mortality. And these are some of the most difficult challenges that we have. What can we do in the DRR community together with the communities that work locally and on the MDG, can work together so that we share the same agenda, so that together we can achieve the objectives of both programs. If we want to make progress beyond 2015 to make a reduction of risk in disasters, we need to also be careful about the other commitments that we have in terms of disaster reduction, but also in terms of the MDG. How can we achieve both? That is the question.
Thank you. A very good question. Would you like to answer that later? Good. Could we go on to the next question further back, please?
Hello, I'm Peniel from India. I work with an organization which is grassroots level healthcare institution. I would like to actually ask the question of how can the top level knowledge and the policies, frameworks trickle down to the lowest level, and how the experiences in the lowest level organizations can be actually brought into a place where some help for the policy making as well, practically implementing the programs. I am from a community-based organization, as I said, and there's a very interesting thing about our organization. 70% of our hospitals in India are in high disaster risk prone areas. Now, because of higher frequencies of disasters, we moved into one unit was opened where I am heading into disaster response programs. And then now when we are into disaster response programs, we are finding that there's a need of actually coming back and preparing our whole healthcare staff and also hospitals for meeting the disasters. And there's a big challenge of lack of resources, lack of capacity building and programs of that sort where we can effectively respond to medical emergencies as such. So how can we, bring these, the lowest level organization converge with the local government? There are always some problems or strictures there to actually combinedly work with it, because it's a huge, highly populated country, and providing services on regular basis itself is a big challenge. And when you have disasters, you have a heavy challenge to meet those things. Actually, this took us to another program which localizing HFA and integrating DRR approach with hospital, school, and community. And that is where we felt that there is a urgent need of converging these local level organizations, institutions, including government organizations, in case of any disaster. How do we respond to effectively? I was talking about the disability inclusive, madam. We also did a brief disability inclusive program in our hospitals, and we felt that it is not very difficult. It can be very easily done and less expensive. Only thing is sometimes you have to really sensitize the hospital staff. What we did is we let when we had an initial discussion with the hospital administration team, they said, oh, we can run with a whole wheelchair anywhere in the hospital. So what I did is I put the administrator to sit on the wheelchair and took him around to the hospital area, essential areas. The first block was in the registration counter, where the counter was very high. And then that was the beginning of reducing the height, leveling, making barrier-free, whether it is bathroom, toilet, whether it's any other services.
Fania, thank you. That is absolutely tremendous example. I love it. I really approve. And there's one more question over here, and I fear this might be the end of the questions and statements if we're going to complete on time, getting everybody to be able to comment finally.
Sí, muchas gracias.
Thank you very much. So I am Roberto Delgado from Mexico. I don't know if it's because of the short time that we have here, but I didn't hear enough about ICTs, because we talk very often about hospital infrastructure, but when there's an emergency, the physicians and nurses are confronted with an emergency. So I think we need to talk about an international, regional network for remote healthcare, virtual healthcare. Perhaps other states can help the state that's confronted with an emergency with very little cost. I think we need to have those networks in place. Thank you.
Thank you. 3 fascinating questions. Really tremendous. The health services and women. I was wondering whether, and how to get communities to work together. Would you be able to answer that for us, Mark? There seems to be quite a lot heading in your direction this time.
Well, I mean, there's obviously no easy solution to getting the different levels to work together, but in general terms, I mean, it requires a few different things. I mean, it requires processes in place to enable that to happen. It requires structures in place to enable it to happen. It requires the will to make it happen. It requires resource to make it happen. Having said that, I mean, if I think, you know, a little bit more practically, I mean, I guess it's about you know, people at all levels in the system not thinking that disaster preparedness is something that governments do and that the capital does. That it should be also about what communities do. And the more you can actually be linking those two together. So I mentioned before very briefly in the New Zealand system that I talked about, like the command and control process that we have centrally, but there's the same sort of thing at the regional level. So we have, you know, we have local committees for civil defence and emergency management, and they're bringing different people together from different communities, different sectors to talk about preparedness and response at their local level. And when there's actually a disaster, they're actually then right in the middle of that response. Now there are ways that local response and also the local thinking is linked to the centre, and that the information flows both ways. But you actually have to take a decision to design the system to support that, because it won't happen automatically.
Thank you very much. Could I possibly ask Bruce to comment on Roberto's request from Mexico about an international network for remote healthcare? I certainly saw an example of this when I was in Canada, how they try and get to systems to very remote areas, particularly in a disaster. But I don't know whether this is on your agenda at all, Bruce.
Obviously, we've got to be, I mean, this links to one of the themes that came up in a number of the questions and comments earlier about whether we're talking in terms of innovation or we're talking in terms of networks, and we're talking communications and information technology, but all of these ways of sharing information and more quickly connecting in emergencies is going to be absolutely essential part of it. You know, the specifics of it, no, they aren't sorted out. I mean, we're still looking at policy frameworks, but obviously this is a big part of the solution. And especially as we're talking about community resilience and empowering the communities, this is an incredible way to be sharing information now. I mean, whether to extend it a little bit to cellular networks and things like this, we have incredible tools now that we just never had before. But these are only going to work if they're set up beforehand. And also we need contingencies, because these things go down in emergencies as well. So it's not that straightforward. One point I'd just like to pick up on for a second, Jeannie, was the Vice Minister made a couple of comments about, you know, physically and psychologically prepared populations, and I think this is such an important aspect of it going into emergencies. And I think one of the things we've learned through the Arab Spring, we've learned a hell of a lot about the mental health dimension of this as well, and I won't go into it, but one of the things that a number of ministries have come back and told me about was we could actually, with the tools today, respond to the mental health issues way better than we could previously. The last thing the Vice Minister shared with us the other day was in Chile, you mentioned you have, I think, 2,000 volcanoes or something like this. 120 of them are active at any one time. I mean, if we can't make the argument for preparedness, you know, there's going to be disasters.
Thank you very much, Bruce. I think that is incredible. So can I just remind you very quickly of these 10 key messages? You have the paper as well. It would be wonderful if you could support this. I hope you agree that these are really key messages. But what I want to take you on to now, as we're so short of time, please forgive me, is something that we've had from Chile. We think, as the first of the 3 outcomes you propose, is that for the health service, it's absolutely key that we have people's health as a key outcome for disaster risk reduction now and beyond 2015. And I think we mean in that being well before the disaster hits. I think you described that quite beautifully, and I'd like to support you, Bruce, very much in thinking that as key. The next key action is strengthen the action and resilience of health systems, including safer hospitals. I think we've had the plea for safer hospitals come through so clearly from Mexico, and the support from Rick when you gave your presentation really impressively. I think the vital need to effectively address disabilities and other emerging and neglected community issues in disasters is vital. And I'm so delighted that we've had the early release of your guidance. And Atif, your advocacy for such an important document and the wonderful questions we've had. And I know it's only the final 3 points, but of course, because it's health and Jonathan, there has to be a fourth. I know we're only meant to present 3 as the outcome of this meeting, but we just want to check that you agree with them. So the fourth, which is really just a third, B, is better reporting and communication of all disaster health impact risks to include injury, illness, disability, and mental health, as well as deaths. We feel we're really concerned that people merely report deaths and that doesn't reflect the impact on communities. I don't know if you feel that these are the priorities we should be taking forward to the post-HFA movement, whether it's called HFA2 or whatever we're going to be calling it, but I think it would be really good. Do you agree that these are most important? And if so, can I just ask the panelists to have one word only to say whether they agree or not? So can we start with you, Rick? One word.
Yes.
Bruce?
We've voted, it sounds like.
Well, of course, you could make this even faster by making us all give the thumbs up. Yes, of course. That's 3 words.
Okay, esta es una reunión en la que es
Yes,
parlamentaria.
this is a parliamentary meeting, so yes, I vote yes.
Atif?
Yes, with strong stress.
Thank you very much.
Well, yes.
Thank you so much for coming to this session, this featured event. But I have a few people that I really must thank. The first is Jonathan. We would never have achieved this without Jonathan. I think a round of applause for Jonathan. The next round of applause are for all our translators. Thank you so much for your help. The next round of applause for all the people who asked questions, made statements, or who wanted to. So that's all of you. I would love you to thank our signer as well, because she has shown how important it is to communicate in disabilities. A huge thanks. And finally, I'm sure you'll join me in thanking the wonderful presentations from our panelists. And this will all be available tomorrow on the website, so you'll be able to see everything. And don't forget to pick up all these papers that are really important that Jonathan has prepared for us all. And please take them and read them, and you've contributed hugely to our discussions. Thank you all so much.
Folks, I think we would be remiss not to thank our chair for getting us through this and on time, and thank our translators. I was late, so I had to speak a lot faster, but thank you, Virginia.